system in addressing road traffic injuries, drowning, violence against women and against children, and in disability inclusion. She has been working on promoting intersectoral collaboration with concerned sectors and strengthening national capacities in assessment and management of emergency care and rehab systems, as well as providing technical support for monitoring and evaluation of undertaken efforts. Hala has been a friend to AKU. We started working when nobody used to talk about emergency care and injuries, and her effort has brought this as a forefront area to the region and internationally. So really happy and welcome to Hamid and Hala for joining us today and sharing their learning. They focus on, as you will see in a few minutes, on the region and link the emergency care as well as what's happening with COVID today. With that, let me hand over to our esteemed speakers, Dr. Ravaghi and Dr. Sakr.
Thank you very much, Dr. Junaid. Dr. Hala, please do a start.
Thank you. Thank you, Dr. Razak. Thanks to everybody. Thank you, Dr. Ravaghi. And let me see if you can see my screen. Can you see my screen now?
We can see the regular PowerPoint mode if you want to make it.
Yeah, I'll just put it in a presentation mode now.
Yes, very good. Thank you.
Okay, then. So thank you, everybody. Good morning, good afternoon, and good evening. We are really privileged and happy to be here and to be continuing our work with the AKU on the different aspects of emergency and trauma care. So in this first presentation, I will be providing an overview of the ongoing efforts in the Eastern Mediterranean region of WHO for strengthening emergency, critical, and operative care. I will start by setting the scene. So what the situation is very briefly, talking about global and regional mandates, more focus on the regional initiative on strengthening emergency and trauma care systems, linking this to the Global Emergency and Trauma Care Initiative and other WHO trauma care resources, followed by a brief introduction to the implications of COVID-19 on emergency and critical care. And this will be looked at more closely by Dr. Hamid in the following presentation. And then I will end with the way forward. So in our region, the 2019 global health estimates show that almost 10% of all deaths in the Eastern Mediterranean region are due to injuries. However, if we look more closely by age, we will see that this can go up to almost 30% in among the 30 to 49 years group, which is 27.5% of all deaths in the region are estimated to be due to injury deaths. And this is followed by the 15 to 29 years group. Sorry, apologies. The same goes for deaths. Again, there is, it's almost, I mean, it's a little bit more than 10% deaths due to injuries of all deaths in the region. And again, the age groups, the younger, are more affected. However, besides injuries, we also know that emergency care encompasses a range of time-sensitive healthcare injuries that are provided for acute medical and surgical and obstetric emergencies, whether they are from injuries, whether these are infections, heart attacks, or complications of injuries of pregnancy. So it is a whole range of conditions that benefit from emergency care. However, as they strive to fulfill the need and provide the required care, emergency and trauma care systems share common challenges in the region. And these were extracted from previous regional assessments that were done in different countries. So there is a lack of holistic approach to emergency and trauma care management. There is poor integration between pre-hospital and facility-based emergency care. There's a shortage of qualified staff. There is limited data and poor linkage to system planning and data-driven quality improvement. With governance and legislation is there is insufficient distribution of and limited distribution of infrastructure and resources, with limited coverage of pre-hospital systems in particular, and of course the qualified, the limited number of qualified staff is linked to the gaps in dedicated training. And there is a lack of standardized clinical documentation. This is further compounded by the fact that emergency situations are prevailing in the region. So most of our countries are either directly or indirectly affected by these situations. So evidence is also available that emergency care works and is effective. The Disease Control Priorities Project estimates that more than half of the deaths that occur in low and middle income countries each year are from conditions that could be addressed by organized pre-hospital and facility-based emergency care. Because of this, there have been a lot of resolutions at the global and regional level, especially that emergency care can help in achieving almost, all the targets of the Sustainable Development Goal number 3 on health and well-being. These resolutions are committing and are obligations by the UN, by WHO, and by member states to address the issue. So one resolution of the UN General Assembly is the universal health coverage, moving together to build a healthier world. At WHO level, at the global level, there are resolutions that have been endorsed by ministries of health across the world, including the most recent emergency care systems for universal health coverage, ensuring timely care for the acutely ill and injured. Another one on strengthening emergency and essential surgical care and anesthesia as a component of universal health coverage. And a third one on health systems and emergency care systems. But at the regional level, there are also a number of resolutions that are of importance, including the one on introducing the framework for action for hospital sector in the Eastern Mediterranean region. And also there is another resolution that includes a commitment to strengthen emergency care systems using WHO tools. WHO is also committed to supporting countries in their endeavors to strengthen their emergency, trauma, and critical care systems through their what is called the 13th General Program of Work, which is the framework of joint collaboration between the organization and its member states. This is at the global level. At the regional level, this is also reflected in a Regional Vision 2023 Health for All by All, which emphasizes the importance of emergency trauma care and critical care as part of the universal health coverage. So to operationalize all these commitments, a cross-departmental collaborative initiative was established in the regional office, in the region. And this cross-collaborative initiative is run across 4 departments of the region: the Department of Health Systems, Department of Health Emergencies, Department of Non-Communicable Diseases, and Department of Healthier Populations. And the whole idea is to ensure that the work taps on all the diversified technical expertise that is present in the EMRO in order to provide comprehensive, as much as possible, and holistic support to the countries on the different aspects of emergency trauma and critical care. In addition, there is also a lot of collaboration, very strong collaboration across the 3 levels of WHO. So the global level, the regional level, and of course, the most important country level. So this initiative has been focusing on doing assessments of emergency care systems in countries and developing roadmaps based on the findings. They have been focusing on capacity building programs that we will be talking about in a minute. They have been focusing on supporting the implementation of the Global Emergency and Trauma Care Initiative, what we call GETI in the region, developing a regional pre-hospital care, profiling trauma care systems, which is an important project that was done with Aga Khan University with Dr. Junaid's Razzaq leadership, and hospital safety indices, as well as critical and operative care. So since 2016, as I said, the emergency care system strengthening was run as a cross-cutting issue. In practical translation of the WHO concept of aligning as one to ensure issues are addressed with collective technical inputs. And I talked about the steps. However, these practical steps so far have only been taken in Egypt, Iran, Jordan, Libya, Pakistan, Qatar, Sudan, and Tunisia, and some work in UAE. And in fact, it was the advent of COVID that caused some issues in slowing down the pace of work, if I may say so. So in the emergency care system assessment, there were different aspects that were addressed, from system organization and governance, financing, emergency care data, quality improvement, scene care, transport and transfer, facility-based, rehabilitation and emergency conditions, as well as emergency preparedness. And besides the emergency care system assessment tool, there is also an emergency unit assessment tool, which is called HEAT. And this emergency unit assessment tool has already been applied in Islamabad in 2 teaching hospitals, and this assessment provided recommendations for the further development of the teaching hospitals in this regard. And we are continuing to provide support to the best of our abilities, of course, in full collaboration with the national counterparts. Also, ECSA in Pakistan was implemented in terms of the assessment. However, the roadmap has not been developed yet. And we are currently reviving this step, and we hope that very soon we would be able also to work on the development of the roadmap based on the priority actions identified by the assessment. In addition, The ECSA has been undertaken, as I said, in 8 countries of the region. However, roadmaps were only developed in Tunisia and Sudan. Nevertheless, priority actions were put forward to countries based on the undertaken assessments. And these priority actions were found, some of them were found to be common across the countries that have done their evaluations. And these are 10 mainly. The first one is the need to strengthen coordination mechanisms. Financial sustainability for both pre-hospital and facility-based emergency care was also identified as an action priority. Standardization of data collection, analysis, and their utilization for quality improvements and system planning. Developing and the need to develop and review standardized clinical charts for pre-hospital emergency care and start or expand electronic clinical charts at emergency units, introducing and strengthening emergency care system legislation and regulatory frameworks, whether for licensing or operations, including norms and standards. The need for formal standardized triage systems and the mandatory national triage system, reviewing and adapting and adopting the WHO-based standards for the different levels of emergency care, strengthening the training for the health workforce for pre-hospital and facility-based emergency care, multi-sectoral disaster preparedness response planning need, strengthening pre-hospital and facility level security services for preventing and managing violence against staff and patients and infrastructure. And in fact, WHO is developing some technical guidance soon on this aspect. So besides the ECSA, the assessments and the roadmaps, other activities have been undertaken in different countries, regardless of whether they develop the roadmaps or not. One of them is the Emergency Unit Management Improvement course to build the capacity of hospital managers and improve emergency unit management. And this is a curriculum that runs through a 4-day course. Based on this emergency unit management, a mentorship program is established following the assessment and is done to strengthen the capacity of the hospitals and the facility level. And this was done in 6 countries of the region, Egypt, Iran, Jordan, Libya, Sudan, and the United Arab Emirates. The other is the hospital emergency preparedness and response, again, another curriculum, another capacity building activity to support hospital managers and health professionals to build resilient hospitals. And it was done successfully in Bahrain, Iran, Libya, and Sudan. Besides this, a regional pre-hospital care framework was developed in full consultation with experts from different countries in the region as well as the global level. And now it is being prepared for piloting in Pakistan, again, to test its performance, its feasibility and implementability at the country level. In addition, there is the Hospital Emergency Preparedness and Response in Communicable Disease Emergencies. This is another course, a curriculum that would be run over 4 to 6 days, and there are preparations to run the first regional course next October, inshallah. In addition, a study was done on the role of the private sector role and engagement towards emergency care services in the region, using a multi-step process to evaluate the situation, look at best practices, and inform public-private engagement, private sector engagement in emergency care systems with development of recommendations for further development of the system. And here I would like to point to the good efforts of Aga Khan in this aspect and the important role it played in providing the services during the COVID crisis. In addition, I would like just to talk quickly about the WHO instrument to profile trauma care systems in the region, which was, as I said, developed by WHO and Aga Khan University. It measured trauma care performance based on the 6 building blocks of the health system in order to identify key areas of interventions for improving it. It was implemented in Djibouti, Iran, and in Sindh in Pakistan, with findings pointing to a very variable, of course, trauma care system needs based on the development of the systems in the different countries. And the instrument is currently considered for revision based on its performance in country level implementation. So this is at the regional level, but besides our regional work, we are also linking, we are one WHO. So we are linking to what is happening at the global level. And one of these important initiatives is the Global Emergency and Trauma Care Initiative, which aims to save lives over the next 5 years through improvements in emergency care systems. We have activities that are running core countries for coordinated implementation and concentrated monitoring of the WHO Emergency Care System Toolkit. So this is currently run in Jordan, Tunisia, Sudan, with close collaboration across the 3 levels of the organization. But other countries are benefiting from it as well, including Pakistan. So among the activities that are being run in countries is clinical training using a WHO ICRC basic emergency care course, screening and triage guidance, and clinical process tools, the implementation and capacity building on using clinical process tools such as trauma care medical emergency checklist, tools, standardized clinical forms, and WHO International Registry for Trauma and Emergency Care, and more are in the pipeline as well. Besides the Getty, there are different WHO resources that could also be found on the WHO webpage. From guidelines to the guidelines for essential trauma care, pre-hospital care systems, for strengthening care for the injured, success stories, and guidelines for trauma quality improvement programs. And these can be found online. I just don't want to go into the details because of the time. In addition, there is a network of government and intergovernmental organizations and NGOs, including professional societies, that is called the Global Alliance for Care of the Injured. And this network provides guidance and support to governments to improve care for the injured in a sustainable and affordable manner through systematic provision of essential trauma services. And again, Dr. Razak and you have been actively involved in this alliance. It has a number of working groups focusing on trauma care system development, trauma registry and data, evidence and research, education and capacity building, as well as advocacy. So this has been going on for the past years. However, COVID came in, and as we know, it had its impact on all of us, all the different aspects of life, mostly health systems and the ability to provide the required care. So for a better understanding of the situation, a pulse survey was conducted by WHO on the continuity of emergency health system, of essential health services during the pandemic, and it presented findings from over 100 countries across the world. The survey showed that there was poorer availability of potentially life-saving emergency surgical interventions, blood transfusions, or drug treatment, which is one of the most immediate and dramatic indirect consequences of the COVID-19 pandemic. Facility closures, staff shortages, or supply issues may have all played a role. Each of the 4 emergency and critical services were affected in 20 to 25% of countries. Severe or complete disruption was not common, but still occurred in 7% of countries for inpatient critical services, followed by urgent blood transfusion in 4% of countries. However, despite the fact that partial or severe or complete disruption of all the 4 emergency services was reported by 15% of countries, only 62% reported that there was no disruption at all in these services. Of course, this is all based on the country responses to the Pulse survey. So in order to support emergency care system functioning during COVID, there has been some guidance on maintaining essential health services, including emergency and trauma care at the global level. At the regional level, there was the cross-departmental approach where Pillar 9 of Essential Health Services was focusing on this issue, on maintaining these services, including emergency and trauma care. A hospital readiness checklist for COVID-19 was developed and was applied in Tunisia, in Jordan, and Iran. An emergency unit readiness checklist for COVID was also developed, pre-hospital readiness checklist as well. And recently, there have been discussions with countries that have been involved or engaged with WHO in working on strengthening their emergency care systems on how to move forward. And one of the countries that were really interested and took the initiative and proactive to engage with WHO in advancing emergency and trauma care, and even now, before COVID has resided, was Pakistan. And there has been capacity building programs on trauma and critical care in Jordan, Yemen, Somalia, and Somalia. These have been undertaken during the pandemic as well. Dr. Hamid Ravaghi will provide more information on the lessons learned during COVID, but I will now end with the way forward. So what we're trying to do now is to streamline emergency, critical, and operative trauma care efforts in the region, and we are having a new acronym, WHO. In WHO, we like acronyms a lot, so we're calling it ECHO for now. We are trying to strengthen and to advance and scale up advocacy and policy dialogues for emergency, trauma, and critical care, focusing on strengthening governance and financing, on extending the efforts to strengthen emergency, trauma, and critical care in EMR countries beyond the 8 to 11 countries where we are working now, implementing the global GETI initiative and extending it to other countries besides the 3-4 countries in which it's implemented currently. Of course, promoting evidence generation and sharing best practices. And in fact, we are also trying to expand our regional collaborating centers for emergency and trauma care to work with WHO on supporting countries and to revive and strengthen the networks, related networks in the region. So with this, I end my presentation. Thank you so much. And this will be followed by Dr. Hamid Ravaghi. Thank you.
Thank you very much, Dr. Hala. I'll share. Hala, can you stop sharing? Then I can share.
I always stopped sharing.
Okay, thank you, thank you.
Thank you.
Can you see my screen?
No, we can't. Yes, we can now.
Do you see the slide sharing more?
We can see the slides, but not the slideshow.
Okay.
Yes, now we can.
Many thanks. Thank you, Dr. Hala, for the setting the scene. I will present the study that we did regarding the hospital experience combating the COVID-19 in the Eastern Mediterranean region, and which is very related to the emergency units and emergency responses of the hospitals. I'll try to be sure to give more floor for the discussion or Q&A. As you know, by today, about 212 million people, we have confirmed cases at the global situation, and unfortunately is 4,439,000 deaths at the global level, and in the region, 14 million confirmed cases and 258,000 deaths. So it shows that really how the problem is challenging and is big, and we need to work on the health system resilience and hospital resilience. And we need a paradigm shift. We need to move from the very conventional to the new normal, to move from the disease-based hospital to the needs-based hospital, and move from individual care to the population health, and shifting from acute care to the providing continuum of care, and fragmented care to the network of integrated delivery service, and also to be moved from reactive to shocks to the proactive preparedness. Really, it was a big lesson learned that we need to have a resilient health system and also resilient hospital within this resilient system. So an emergency care system in the heart of this resiliency. And so we can see the role of hospital in emergencies. COVID-19 showed how hospitals are important, but it should be in a PHC-based model and PHC-based approach. And emergency healthcare is the first point of contact in EMR. Why we did this study? Really, we needed more context-specific evidence to show the important role of hospital as a backbone of the health system, as we had a high surge of the patients and the COVID-19 patients, and also we needed to maintain the essential services. And unfortunately, in the region, about 50% of the countries out of 22, they are facing in emergencies in different stages. So we wanted to explore and document the EMR hospital experience, which challenges they are facing, and which intervention they are using, and the lessons learned. We did a comprehensive study. We did 3 rounds of the literature review, followed by the 46 key informant interview from 18 countries, and having the online survey with 139 respondents from the 14 countries. And we approached the hospitals that as a designated hospital for COVID-19. 93% of the hospitals were admitting the cases, and 91% of those hospitals were public hospital. And as you see, the participants were health professional, directors, clinicians, administrative, and nurses. And from the different, range of hospitals, from the 100 beds to more than 400 beds, from the small to the large hospitals. We use the WHO hospital readiness checklist that Dr. Hala referred to. That this checklist covers 10 domains, and each domain has some questions. That covers the leadership and coordination at the hospital level, operational support, logistics and supply chain management, information, communication, HR, continuity of essential care, identification, diagnosis, isolation, and clinical and case management, and the infection prevention and control. I don't want to go to report the results in terms of the shortage of time. I would like to go for the main lessons learned that we found, and we realized that we need to take care of it. And for each these 10 domains, I provide a main lesson learned. The first one, it was that we realized that many of the hospitals were not prepared, and even if they had a preparedness plan, most of them it was on the paper and not aligned with the training and also the exercises, drills. So really we need a proactive and holistic approach. We need to improve the hospital resilience, and our hospitals need to have all hazard preparedness plans. And what we learned from the AKU, that it was a good preparedness plan, and the AKU University Hospital was one of the hospitals in our sample that they showed they were relatively prepared, and they were agile, and and they were able to adapt themselves. Really, there is not much financial support for preparedness. We need to increase fiscal space for health and flexible spending on emergencies. We learned it a lot, and the policymaker needs to pay attention to this. And so simulation exercises are very important, even if we have a plan. Without these exercises, the hospital will not be practically prepared. In the domain of the leadership, we realized most of the hospital managers, they didn't have enough capacity, managerial capacity and knowledge in terms of the hospital emergency preparedness and management. And also they were not adaptable and agile enough. Decision-making was so slow, and the accountability lines were very ambiguous, and this is the area that we need to improve. And also different leadership style needs to be promoted. We saw a not very efficient and effective leadership style during this crisis. In terms of communication, really a stigma affected the function of the health system and hospitals. We need to combat the stigma by collaborating with media. We need to engage community actors, religious people in Pakistan, Iran, Sudan. We saw how the religious leaders, they were helping for the community involvement. The intra and inter-hospital communication lines needs to be improved, really. And the social media has a very important role. The WhatsApp message was one of the the tools that have been used by the health professionals. Even many of the people health professionals were consulting with their colleagues. For example, Dr. Junaid in US, the people can consult, or we had a diaspora activity in many countries. And also one thing that we faced that it is missing, it was the lack of feedback, constructive feedback from and to MOH. There was not good surveillance system, good communication between hospitals and MOH, and there was not enough guidance from the MOH and constructive feedback. In terms of human resource planning, most of the countries, they didn't have good HR planning and contingency plan for HR. We learned it should be really improved. And capacity building on infection prevention control, critical care specifically, leadership and emergency management needs to be improved. Many countries, they use the preliminary incentive system, but it was not effective, or sometimes it provided some challenges because the staff, they realized that it is not fairly distributed. So we need appropriate incentives, financial or non-financial. We learned it is very important. And also we need to optimize capacity of health workers using the telemedicine. In many countries, the health workers were not able to use even the preliminary stage of the telemedicine. IPC was one of the main important issues that we really need to evaluate and assess IPC measure, specifically in emergency units. In many hospitals that we studied, emergency units didn't have good IPC measures. And also, we need to learn from past. In some countries like Saudi Arabia, they learned a lot from MERS before, and they were more prepared than other countries. So we need training and monitoring on IPC and having a focal point for IPC in AKU, we realize that it is a strong. Why I'm referring to AKU, because to show it is a really best practice, and also protect health workers and safety of the workers is an important issue that we need to pay attention. Supply chain management is what really was an issue at the global and country and even regional level. We need effective and efficient supply chain management. And even in some countries, we had enough supplies, but the distribution was not very effective. We need a risk-adjusted, equitable allocation and distribution of the supply. And we need to build the capacity of countries to produce, and bulk purchasing can help a lot in this regard. In the search capacity, really now we learned that we need a scenario analysis to see what happened in the future of the hospital, how many patients we may have, how much resources we may need. So scenario analysis is a good tool. We need to scale up the telemedicine and also use all existing resources. Many of the countries, the private sector and non-for-profit sector was not involved in the first stages, and they were, just making themselves away. But we learned from the AKU University Hospital was very involved in Indus Hospital as well, was very involved in Pakistan. They had a very important role at the policy level and also at the service level and facility level. Really, we need adaptable and agile hospital. Even if we are prepared but not adaptable and agile enough, we may not respond to the emergency and crisis. For clinical management, we need an updated triage system. One of the weakest, point that we realized was that we have good triage system in many hospitals in the region. We have the clinical guidelines and update them and train the staff on this. Sometimes there was a controversial guidelines from Ministry of Health coverage were not able to respond to the crisis. So we need to have, the health security, essential public health function within the system. I stop here. I really appreciate AKU for inviting us, and me and Dr. Hala are happy to respond to the questions. Thank you.
Thank you. Thank you so much, Dr. Hala, Dr. Hamid, for making us realize how critical, first of all, how critical the role of WHO is in bringing the evidence that is practical together and enabling the countries in the region to take action. So thank you so much. I really appreciate all the effort that the emergency care and now ECHO, the emergency critical care and operative care, is doing. And one of the challenges, as you know, we have always had is how do we measure success, and how do we create evidence around it? And as we all know, the need for doing more is so critical that sometimes evidence has to be generated while the work is being done. So I think, if you could just talk a little bit about creating evidence while the work is happening. And also, I really liked, Dr. Hamid, your slide on moving from acute care to resilient health system, from responding to preparing. I think that slide for me was a great learning experience, because you captured everything that is wrong with our thinking right now, traditional thinking, and where do we need to go. Also, to the audience, if you can write your questions. I know there's one question for Dr. Hala that she can address. So over to you, Hala, about the evidence and as an academic entity, how AKU and others can support.
Dr. Hala, please, you first, and I will follow.
Would you like me to respond to the question in the chat box, or would you like me to?
No, you can go ahead and just respond to everyone. You can talk about the response.
Okay, so regarding telehealth and telemedicine, I think that this is becoming more and more if I might say, fashionable. And at the same time, it proved to be a savior at times in the COVID crisis, frankly, depending on the context, because in some cases it cannot be applied. In some contexts, due to different reasons, whether due to the nature of the provided service itself, or due to the lack of access or capacity. It depends on the level and on the context. However, it is an evolving area, and there's a lot of work that is being done in this regard. Dr. Hamid, in one of his slides, mentioned teleconsultations for critical care. And some experiences, we know of some experiences in different countries to apply this in the area of emergency care and critical care, at least in decreasing or reducing the number of care providers within units, and doing like teleconsultations with the consultants that might be more at risk, if I may say, due to age or due to the comorbidities or whatever. So it is still evolving, but it is definitely of use. We need to explore this area more and generate more evidence and look at the best practices in this regard. However, taking into account the different contexts, especially in low and middle income countries, it is important, I think, that the context is taken into account in this regard. I don't know if Dr. Ravaghi has anything further to add.
Thank you. Thank you, Dr. Hala. Just a few issues I would like to add. Dr. Junaid, now we see we are, facing a revolution, I think. And the whole service delivery and also health system will be changed very, very quickly. And also for this reason, we need to see this revolution from system perspective, from the digitalization and governance, regulation, and also the activity of the health professionals should be reimbursed. So we should see that from the purchaser point of view as well. So regulation and also the governance is important. Also, the capacity of health workers is very important to understand what do we mean really digitalization and digital health. And also the mobile app and applications can help a lot in this regard, and WHO is working on this clearly. And one more important issue that we need is a financing point of view for this. Really, we need a good financing system that they understand that this needs a lot of huge, investment, but it provides better access and also community raising awareness. Now I see even some of the community members, they rely on the digital health, digital consultation. Sometimes when we say that, no, I want to go and see my doctor face to face. Now after the COVID, they are relying that they can receive the good care if the technology is easy and user friendly. Thank you. Over.
Thank you. There is a question that was about hospital accreditation. Somebody wrote that the hospital are going to ISO or Joint Commission, and is there a plan for WHO to be involved in quality assessment and hospital accreditation?
Many thanks. In the regional office, we have one of our colleague, Dr. Mondar Latayev, is responsible for quality improvement and accreditation, and we have the clear policy and clear strategy to support accreditation of the countries in the region. We have supported, for example, Sudan. We are supporting Pakistan, and also we are supporting few countries in collaboration with the with the countries, because in the region we have three established national accreditation bodies that they are providing national accreditation. One is Saudi Arabia, one is in Jordan, and one is Lebanon. Other, they do have, and they have been internationally accredited as well, specifically Jordan and Saudi Arabia. We have some kind of national accreditation programs that have not been internationally accredited, but it is ongoing in their own countries like Iran, like Oman. Oman is working on this. However, some of the hospitals in the region, including AKU, they have got international accreditation. For example, AKU is JCI accredited. Some of them, they went for the Canadian accreditation, some for Australian accreditation. But definitely we are supporting accreditation. However, accreditation is a tool. We don't put all of our strategy in one basket. Accreditation has its own pros and cons, but we support accreditation programs. And if any country needs our support, we are able to support at the hospital or at the national level. Thank you.
Great. That really brings us to the end of the session. We have a minute to go. So with that, I'd like to thank again the speakers and also our team at AKU, Dr. Shahid Raza. He's the Senior Manager of Center of Excellence for Trauma and Emergencies, and Dr. Huba Atiq, who is the Assistant Director here with us. So thank you both, and thank you again, Dr. Sakr, Dr. Ravaghi, for sharing your knowledge, and we really look forward to working with you in the future as well.
Dr. Junaid, I really appreciate, and really also we are seeking the collaboration with AKU, and I'm sure we can have, the much more closer collaboration with AKU, and looking forward to working together on the different aspects of emergency care. Thank you.
Thank you so much.
Thank you. Thank you so much. Thank you.